63-year-old lady with a background history of thalassemia major. She presented with upper abdominal pain and also left upper quadrant fullness in October this year. There is no documented history of hospitalization of pancreatitis. CT was done last month, showed 12 centimeter large cystic mass at the left upper quadrant with thin partial wall calcification and also internal septations arising from the distal pancreatic body and tail. There is no intralesional mural nodule. Upstream splenic vein was obliterated, with a resultant left side portal hypertension and moderate perisplenic, gastric, and also gastroesophageal varices. Differential diagnosis including cystic lesion, cystic neoplasm versus pseudocyst. This is the CT finding. So today we are going to perform EUS plus or minus through the needle microforceps biopsy and cystic fluid analysis by Professor Tang.
Hello, good afternoon everyone.
Hello, Raymond.
Here is CT with Raymond in the room. So
hello.
As you can hear, we have a lady presented with some mass effect because of a quite large pancreatic cystic lesion. So unfortunately, her splenic vein was also obliterated with some varices. So actually, Raymond has already got some anatomy, but I guess those organs are quite displaced because of the big lesion,
yes.
right?
Yes. So as you can see from the CT scan, the cystic lesion is so big that it displaces adjacent organs. So what I find in the stomach is the stomach has a bulge and then there's a J-shaped configuration. So I'm able to eventually manipulate the linear echo endoscope down to the D1. So I'm using Olympus linear UCT 260 echo endoscope and EUME3 processor. So now my scope is in D1 with a long scope position. So as you can see here, now I'm trying to show you the common bile duct and also a cystic duct. I'm sorry, not cystic, the pancreatic duct here. Now, can you appreciate on top there is a tubular structure that has no flow, and that's the common bile duct? So can we freeze? No. So we can maybe make a measurement and take a look, see if the CBD is dilated. So it's about
yeah, it looks
4
like
or 5.
All right.
Yes. So now, then if I turn to the right a little bit, can you see that now there is a small non-dilated PD. Now, yes, so where the green arrow is, so now this is the PD. So I'm in the pancreatic head region, and I believe what I'm seeing as a big vessel here, that's the portal vein. But it seems like the portal vein is somewhat prominent and dilated, so maybe there's some degree of portal hypertension. But here, if I turn the scope more, I can see that actually there's a PD going to the neck and body region. Now, can we show the, now this is the neck region, the PD and the neck region. So I'm trying to see if the PD will go into the big cyst. And why I'm not imaging it from the stomach yet, because the cyst basically taking up the whole screen. The whole screen can only show the cyst and cannot show the pancreatic parenchyma. So now I'm showing you this is probably a non-dilated PD, maybe just a little prominent, maybe 2 millimeter, a little bit more. And this is going back to the neck region. So with this in mind, I'm going to pull back the scope. And now back to the stomach. Now, can we give a little bit more sedation? Can we give yeah, a little bit more? So now what I'm going to show you here is the big cystic lesion. Now can we zoom out? No, can you the other way? Now zoom out more. No. So I rarely use a very deep penetration depth. Now, but for this big lesion up to 12 centimeter, I have no choice but to use a 12 centimeter depth of penetration in order to show you the whole lesion. Now, I think there is some echogenic material in there. Now, there are 2 layers. So some less probably echogenic area is up here, but then maybe there's also layering of echogenic material. So, but patient has no history of pancreatitis, so I don't know if this is debris, but what I'm suspecting is maybe we're dealing with a mucinous cystic lesion. But we're going to find out soon. So, and now can we turn on the Doppler? Now, I'm just going to show you that there are varices in the area due to compression of the splenic vessels. So can you see there's some varices here? But of course, I'm trying to stay away from them. So here, my job is to find a good window. So here, I think I'll be able to get a window for puncture here. So I'm going to hold the scope like this, and then we'll get ready for needle puncture. My plan today is...
Raymond?
Hi, yes.
Before you puncture, I just want to see whether this is a retroperitoneal cyst is not from the pancreas.
The CT scan actually showed that is communicating with the pancreas. The cyst is not separable from the pancreas. So
Okay.
that's why we wonder if this is, from the pancreas. And then the patient actually has no symptom before, and the symptoms were actually happening in the last few months.
Yeah, that's why I'm saying is actually sometimes this is a retroperitoneal cyst. They usually present just on the CT scan as an incidental finding. They don't actually have history of pancreatitis, that sort of thing. So I'm just asking whether that may be a possibility.
I guess there's also a possibility, but if I trust the CT scan saying that this is actually coming from the pancreas, then for just to clarify diagnosis, I think probably we can use fluid analysis and also through the needle biopsy to get some tissue to clarify the diagnosis here, because I guess because patient has already also presented option of surgery because she has symptoms from this, and she had early satiety and a bloated stomach after eating. So, but she doesn't want to go to surgery without a diagnosis. So this is actually per the patient's request.
Okay, so you had a needle now.
Yes.
So just now, Raymond, you mentioned we are going to do some fluid analysis. So can you simply outline what kinds of investigation you are going to send with these fluids?
Oh yes. So we have a window here. Now, so we can turn off the Doppler. Now we are ready. So now here, I am using a 19 gauge needle, the Olympus EC Short 3. And then so what I'm trying to do is, now I'm trying to make a puncture here. Now, so it's quite easy to go through pretty thin wall. Now, so in our style, that's all. So then we're going to we're going to aspirate some fluid and see what this is. But we have an HPP surgeon here, so we're talking about probably unlikely to be a pseudocyst, right? Yeah. So now let's now we're going to find out what the fluid looks like. So okay, high. Yeah. Okay.
So of course, just now we are trying to say what kind of fluid analysis we'll see. So of course, I think Raymond is correct.
Yes.
First of all, the appearance of fluid actually matters.
But then now here, I may actually have to refine our thinking here. So now we're seeing some brownish colored fluid.
Yes.
Now this may be more commonly seen in a pseudocyst. So of course, pseudocysts can have the straw colored fluid, but now here it also doesn't look like the typical fluid that we see from a mucinous lesion.
Maybe can we zoom in
Yes.
to
Or
have a
maybe
look?
have a gauze behind so we can show the, yes. So can you see
Can
the
you
color of the
appreciate the
fluid?
color of the fluid? Quite pigmented,
Brownish.
dark brownish.
And no, it doesn't look very viscous too.
Yeah.
So I guess the possibility of a pseudocyst is still possible.
It's not excluded.
Because
I think.
we also have aspirate fluid from, for example, duplication cysts or retroperitoneal cysts before, but usually the fluid would not be this color, usually. So, but anyhow, so we have some fluid here. Now, so we are going to send this fluid, for analysis, and at the same time, we'll aspirate some more fluid out before we do the, through the needle biopsy. So now let's aspirate, let's squirt out some fluid here. Yes.
So Raymond,
Yes.
Is there what would be the optimal volume that will be required for good analysis?
Yes. So now what we are planning to check today is fluid amylase, fluid CEA level, and also fluid glucose level. So, and then,
Yes, we got a
and also,
glass plate just now. Here.
and also, we may actually send it for cytology, but then I guess it doesn't really look like a neoplastic cyst at this stage, so I may not send cytology, but fluid amylase and the volume, I think at least 1
Yeah,
ml
I don't think so as
for
well.
each
Yes.
specimen. So now, yes, do you see some any
Yeah,
string
it's
test?
very kind. Professor Chang came
Yes.
in, like he
Yes.
kind of personally tried the fluid.
Yes, so
not viscous at all, right?
not viscous at
yeah,
all,
it
right?
looks quite fluidy,
Okay.
yeah.
Yes.
But I guess, like for example, sending the fluid for like amylase can help you to
Yes.
differentiate between this is pseudocyst or not.
CA.
But I agree, initially we all thought like it's kind of mucinous. Probably we
Yes.
need to wait for further analysis.
Right. So, and then why I still aspirating is because if I starting to do the through the needle biopsy now, I think the target will be a little bit far away. So I'm going to try to empty the fluid as much as I can to collapse the cyst a little better before I, do the biopsy. Okay, 所以你睇下，可以俾一個。好。So we have the through the needle microbiopsy Moray forceps, and I have already inserted into the 19 gauge needle. Now I'm going to push it out of the needle. Now can you see this device coming out?
Yes.
Yeah, now let's open the forceps. Can you see it open?
Yeah.
Yeah.
Yeah, the white shape.
Yes. Now I'm going to push it at the wall. Now slowly closing. Okay, now closed. Okay, now can you see that it lifts up and then I got a little bite? So I'm going to let the nurse check it out. So I think the key is, let the forceps close slowly because otherwise it will slip off. And sometimes when you pull on the forceps, just be gentle. If I pull too hard, they may be bleeding. Yeah. So let's see if we get some tissue.
Maybe.
So I think now, at least here, I do not see, some, like a whirlpool or like some echogenic material re-expanding the cyst. So I think we are quite okay here that there's no significant bleeding here.
So how many bites will you take?
It depends on the tissue specimen size. If I do not see a macroscopic specimen, then I may go back in to take some more. But at least 1 to 2 bites. So, even though this is already a bigger forceps than just the needle itself, then, I hope we have something that can be seen with our naked eyes, So I'm looking for some macroscopic specimen. So you think there's some macroscopic specimen?
There's a tiny bit, so our nurse is trying to retrieve it. But I think we'll do 1 to 2 more passes
Yes.
at least.
Yes.
And actually, some studies has been ongoing to evaluate this use of through the needle microforceps biopsy, whether diagnostic or not. Like Raymond, what do you think about this?
In my practice, I don't routinely puncture pancreatic cystic lesions, especially a small lesion. I don't think we need to puncture. But for lesions that has a confusing diagnosis or it may change the plan, such as OT or not for the patient, then I would first discuss with the patient and if, and also maybe talk to the surgeon. And if everybody thinks we need to clarify diagnosis, then I think this technique is quite helpful. So, but I guess my message is I don't routinely puncture, so especially small cysts. But this one, or a cyst that is maybe up to 2 to 3 centimeters in size with indeterminate morphology, I may do it, But of course, nowadays with good MRCP, if clearly the cystic lesion has ductal communication suggestive of BDIPMN and no history of pancreatitis to suggest a pseudocyst, I think some of the doctors will comfortably be calling this, suspected IPMN, or presumed IPMN.
True. Okay, so
We are ready for
For another.
another
yes.
bite.
No. So we can show you how small this forceps is. Now, maybe we can zoom in. Now, we're going to hold a glass behind it. No. So can we zoom in? Now, can you see? So even though this forceps can, get a visible specimen, but again, I have to say that it's still kind of tiny. So we just have to be patient and handle it with care. Okay, I'm going to go in again. So
Okay.
let's close.
What is the size of the forceps? Like a guy wire or?
Okay, so Ting Ting can help us here. So now, what is the open jaw here? Open jaw is
Okay,
about 4.
the open jaw is about 4.3 millimeters. So when you open all the Y-shaped blades of the tooth, so it costs you like 4.3 millimeters. And the forceps itself, the Kevlar is measuring like 0.8 millimeters in diameter.
Yes. Now, what you can see, why there's something coming out of the needle, those are not blood. I think that's just debris from the fluid. Now, the forceps is coming out. Can you see the forceps? Okay, let's open. Now, it's open now.
yes.
So I'm going to push on the wall, now slowly closing. So snugged, right? Okay. Now I'm pulling back. Now I got a feel that, a tactile feel that
Yeah.
I grabbed something. So now let's
That's
check.
a little bit rebound like after you withdraw.
So I think we're doing pretty good here. No bleeding. So I think I would say I think so far we're doing quite okay.
Yeah, the biopsy is really impressive. I mean, the EUS view that you get the biopsy is very reassuring. Yeah, thank you so much, Raymond, and thank you, Ting Ting.
Okay, thank you.
Yeah, thank you.